Good morning. First of all, I'd like to welcome you all and thank Carly and Andrea for their hard work in putting this together. I know I've been a participant for most of the 18 years, and it's amazing how this has grown, how our group has grown. We're now 6 campuses ranging from Westminster, and we recently opened in Greeley, so if anyone has a chance, swing by and see the Greeley facility. It's been great. But anyway, moving on. So you'll probably notice that my talk today, I think, is entitled Bee's Knees, and I'm not really sure what that means, but I didn't know what I was going to talk about, so Carly put a name on it. So a couple days ago, I decided what we should talk about today, and I hope there's some interest because it's a kind of a confusing topic. But I think it will, for those of you who see ACL patients, take care of ACL patients, see ACLs, this maybe will help you understand where we've gone or where we're coming from, where we're going, and how confusing it is, and how some of it doesn't make any sense. So I'm gonna present more questions probably in your mind, which is good, than answers today. So, injuries of the anterior cruciate ligament. Where have we been? Where are we going? And why? First of all, injuries are pretty common. There's probably over 200,000 ACL reconstructions performed in the United States per year, and it's pretty well established that the anterior cruciate ligament has a poor healing potential, so it really doesn't have a good ability to heal on its own. Doesn't mean it'll never heal, but it doesn't have a very good healing potential. So if we look at the history, and actually as I started looking into the history of ACL tears, I was surprised to find that some of the things around knee anatomy and a trick knee or an unstable knee have been around for a long time. You can see starting clear back in 3000 BC, papyrus described knee anatomy. Hippocrates even talked about knee subluxations. Galen, so some of the big names in the history of medicine were interested in this particular topic. And I won't go into all the details, but you can see that even clear back in the early 1900s, they were talking about how they can stabilize the knee. And in 1916, Jones remarked that he felt that repairs were futile. So that told us that in a lot of ways they were already trying to repair ACLs, and they were also reconstructing them. Now, what that meant, I'm not really sure, but they were trying to deal with this problem. Again, this gives kind of a quick history of some of the eras or the changes that have happened. In 34, hamstring reconstructions for ACL reconstructions came about. The patellar tendon was introduced in 1935. It became more popular even in the 60s with a physician by the name of Jones. To me, the early ACLs were always called the Jones procedures, but they were pretty archaic, and there were a lot of problems, as you can imagine. But you can see we've gone through a number of different attempts to stabilize the knee, and ultimately, the changes tell you that none of them work great, and that we have problems with all of them. So, how did we get here, and where are we going? And understanding the history of ACL surgery in a lot of ways, I think, will help us understand some of the things you're starting to see out in the world. I mean, how many people here take care of ACL patients or see ACL patients? Perfect. Good. Because you're going to hear about some of these things, and they'll be confusing, and you'll wonder, why am I hearing about these things, and do they make sense? And sometimes the answer is yes, and sometimes the answer is no. Let's start with some of the remote history of where ACL surgery started, or how modern stabilization procedures started. Back in the 1960s, they started doing what we call extra-articular procedures. So they did some crazy things where they would move tissues and move tendons, and you've seen all the big scars that went along with those, and then they would put patients in casts for 6 weeks. So a lot of these were what we call anterior lateral tenodesis was a very common one back in those days, along with tendon transfers. Almost every patient went into a cast, often because there was a complete disconnect with how important the meniscus was. A lot of times they did a complete meniscectomy, which you think about that today and you think, oh no. But that's what happened. The results were poor. Restoration of motion was associated with return of instability. So the patients who became stiff did not struggle with instability. And what that tells us is a stiff knee is a stable knee. Now, it's not a comfortable knee. It's not a good knee to have, but it's not an unstable knee. So in a lot of cases, they considered that a success because the patient didn't complain about continued instability. And stiffness was almost universal because that's what was needed to provide that stability. Now, as that went along, probably back in the late 80s, but particularly in the early 90s, well, back in the 80s, let's back up a little bit, full motion was really discouraged. And so patients had reconstructions, and they were discouraged from regaining all of their hyperextension, and the idea was that we wanted to make them a little stiff. And that goes clear back into the 80s, and that concept came from the extra-articular reconstructions, because if an extra-articular reconstruction became normal as far as motion is concerned, they were loose. So that carried over to the early ACL reconstructions. So almost every ACL reconstruction back in the 80s still went into a cast, and stiffness was the common result. So moving up to that point, then as we move into more modern ACL reconstructions, what did we see? Well, early reconstructions, we accepted stiffness for the sake of stability and underappreciated the risk of osteoarthritis. So we underappreciated what it meant to be stiff. And really, a stiff knee, although it's stable, it changes your joint forces tremendously. A stiff knee wears out. A stiff shoulder wears out. I mean, stiff joints, they're not healthy, they're not comfortable, but I think they get arthritic much sooner than a normal knee, even after trauma, because that stiffness changes your joint forces. So rehabilitation became more aggressive in the early 90s, and really it all came out of a study that was trying to show that patients who had reconstructions and followed the rules of rehabilitation did better than those who didn't. And what they found was exactly the opposite. The patients who were non-compliant, didn't pay any attention to the rules, regained all of their motion, had a more comfortable knee, a better functioning knee, and they didn't lose stability. So that's really what started the progression into what we call accelerated rehabilitation. So that comes clear back from the 90s. So it resulted in less knee pain, no change in stability, and probably decrease in joint forces. So along those lines, because motion became so much more important in the process, we started to shift towards trying to find graft options. So that the graft option that was most common back in the early 90s was a patellar tendon graft. And here's a picture of a patellar tendon. It's on its side a little bit there, but it shows you're taking a graft from the center part of the patella with a piece of bone from the kneecap, piece of bone from the tibia. But it was associated with anterior knee pain and increased osteoarthritis. So that was the feeling about patellar tendon grafts in the early days, and it led to an increase in hamstring grafts and allografts. Now, after the phase of trying to change from going from a more aggressive, more traumatic graft to a hamstring, to an allograft. Then we came into this period where we started to understand, if you're getting the theme here of we've wobbled all over when it comes to ACL reconstructions, hopefully that's what you're hearing, because that's really the story. We then shifted to this subtle acknowledgement of surgical failures, that these patients didn't do as well as we proclaimed, or that maybe we thought, and they're hard to track. They kind of disappear, but a lot of them did very poorly. Now, today, I don't think this number across the board is true, but most likely, ACL failures are much higher than we appreciate. There's some people that actually are saying, hey, we don't know for sure, but failures might be close to 30%. Now, I think that's very surgeon dependent, rehab dependent. I mean, there's so many factors that go into it. Experience is a big part of it, because this is a very technically demanding surgery, and I think there's a wide variance of how these patients do, but certainly failures are much more common than we like to admit, or that we wish we were seeing. So that led to this period of better graft options. So now we shifted away from, hey, let's use the least traumatic graft that we can use, to, we don't care how traumatic it is, let's try to find a way to make stabilization more consistent and less likely to fail. So that led to things, again, it's led to a resurgence of patellar tendon grafts, or what we call bone tendon grafts. It led to, and we'll talk a little bit about quadriceps tendons, but it led to recent use of quadriceps tendons, and it led to the concept of double bundle reconstruction, which basically is trying to reproduce the normal anatomy of an ACL. The ACL is a little bit beyond the scope of this talk, but an ACL is made of two bundles, posterior lateral, anterior medial, and the point is it's hard to reproduce normal anatomy with one single bundle, which is what we use when we reconstruct ACLs. Now, even more recently, even though we're using more rigid constructs for our reconstructions, we're starting to see topics that are related to what else can we do that might increase our stability and decrease our failure rates. And I don't know how much of this that everyone's been exposed to, but ALLs is the anterior lateral ligament, which is a little ligament on the anterior lateral aspect of your knee that probably 40% of the time is injured, but it's a very small ligament. So there's been a phase where we've tried to repair those. I haven't seen a value to it, and pretty much the studies at this point are telling us there's not much value to that in increasing stability or decreasing failure rates, but that's something that's still out there. We're reintroducing lateral extra-articular tenodesis. So if you'll notice, that's something we talked about on some of the early slides. So now there's a resurgence of, should we be adding this in addition to our interarticular surgery? And internal brace augmentation, which is really just a synthetic supplement to try to help stress shield the ACL graft. So let's talk first about some of the patellar tendons, and then we'll talk about the pros and cons of the graft choices, and then we'll talk a little bit about some of those add-ons that we've talked about. So first of all, the patellar tendon graft is the gold standard. It's a predictable graft. The cons are we deal with patellar tendinosis, sometimes for well over a year, and stiffness is more common, which makes sense. If you put a hamstring graft in, you can stretch that out. It's a soft tissue graft. So if you're aggressive with your rehab, you can stretch it out. So it's a more forgiving graft, but a less predictable graft. So this is a much stiffer reconstruction graft, and that makes it much less forgiving. Quadriceps tendon grafts are a new I don't want to say they're new. That's not true. We've used quadriceps tendon grafts probably since the 90s, but they've been reserved for salvage procedures for these patients that have had multiple reconstructions and have had failures, and they've had 2 patellar tendons harvested, and that's led to the use of quadriceps tendon grafts, and it's a very robust graft. So the pro is it's 1.9 times the volume of a patellar tendon graft. So it's almost twice the size of a patellar tendon graft. It has limited tendon soreness. It's amazing how little tendon soreness or tendinitis we get with quad tendons. But it's amazing, too, how much more difficult this graft is to rehab in the early phases and how much leg strength they lose. Now, they tend to catch up down the road at 6 or 8 months, but the early part of the rehab is pretty dramatically different from a patellar tendon graft. So you have a delayed strength return. So I don't know where we're going to go with quad tendons. I use them now in my high-risk patients, the young patients, the 16 and younger, and we're starting to use them more in our CSU athletes because they're a high-risk group, certainly for failure. Double bundle reconstruction, this is worth mentioning because even though it's fallen out of favor, this is reproducing the normal anatomy of the ACL, and it's fallen out of favor because I think it was technically too difficult to get the tunnels and the graft where it belongs, and that we saw increased complications. So it's a great idea. I think it's a great idea, but there's increased complications, and it's been shown that there's no change in the failure rates. But I think it's partly because it's a technically demanding surgery that we don't know how to do properly at this point. ALL repairs, which we talked about, which means that we repair some extra-articular torn ligament. I'm not sure what the pros are. Really, it's more surgery, more chance for complication, and it hasn't been shown to make much difference in re-injury rates. Now, this is one that's very popular nowadays. This is lateral extra-articular tenodesis, where this is kind of a diagram of what happens is you take a piece of the IT band here off the tibia, and you take this detach it, swing it under the lateral collateral, and then you tack it down into the femur, and that's a lateral extra-articular tenodesis. And there's different variations on this particular add-on or this surgery. But the pros, if you listen to the advocates of this, is that it provides greater rotational stability. That may be true. But it also stress shields the graft. So the thinking is you do this and it stress shields the graft while you're going through rehabilitation, which I think is probably not the right thing to be doing for ACL grafts. You want to stress ACL grafts, but you don't want to stress them to failure. Now, we've learned through a period which we didn't really talk about today, where we used what we called LADs, which were synthetic augmentations to the grafts, and what we found was that failure rates were higher because we were shielding the ACL while it was going through this process of maturation. So we're trying to turn a tendon into a ligament, and that process takes time, but it also takes appropriate stress on that ligament, or the body doesn't know how to remodel it or change it. So I'm not sure, even though that's considered a pro for lateral extra-articular tenodesis, I'm not sure that's a positive. The con is you're going to see some patients that develop some stiffness, and that's because this can easily be over-tensioned. And really, that's how it worked back in the early days of ACL reconstructions. It worked because it made you stiff. And hopefully, one of the things that you take away from this talk today is stiffness is bad. It doesn't feel good, and it makes your joint wear out. And it's a con, I think, that it's stress shielding the graft. Internal brace augmentation. This is a procedure where you put a synthetic tape along with the ACL to try to help stress shield the graft. Again, this gets into the concept of should we be stress shielding grafts or shouldn't we? And I think overall, certainly over shielding the graft would be a bad thing as far as failure rates in that maturation process. So, bottom line is I hope that you're listening to this and you go, this doesn't make much sense. It's very confusing, and that's really, I think, where we are with ACL surgery today. I think we're being more honest in a lot of respects as to what our problems are. I think the major problems are number one, and I consider the absolute worst problem acutely after an ACL reconstruction is stiffness. I mean, we'll hear some we'll hear some speakers who do a lot of ACLs that will say that an acceptable stiffness rate is around 12%. Okay, I think that's ridiculous. I think this number should be less than 1%. But there's a lot of things that go into that we'll talk about if we're going to make that number 1% that have to be done. Failure rates, obviously, we don't really know what those failure rates are, and part of it's because it varies so much from region to region, surgeon to surgeon, and a whole number of other things. And then osteoarthritis. Certainly osteoarthritis after ACL tears that's a significant problem. It's amazing how few instability episodes you have to have for it to just trash your knee and to lead to osteoarthritis. But it's also amazing how fast an over-tensioned ACL graft can lead to osteoarthritis. So what are the solutions? Well, stiffness, certainly I think rehabilitation plays a large part, both before surgery and after surgery, and there has to be an emphasis on full range of motion, including hyperextension. So all the concepts around, hey, if you lose a little bit of extension, it's okay, and it adds to stability, we need to get that thinking out of our head, because that's what leads, or partially leads, to osteoarthritis and to a knee that doesn't function very well. We really need to focus on more accurate and precise graft positioning. In other words, we need to do the surgery better. We need to do a better job at putting the graft in the right place and tensioning it appropriately. Failures, again, maybe the answer is more robust, predictable grafts. But again, if you use more robust, predictable grafts like patellar tendons and quad tendons, we need to be more precise in where we put them and how we tension them, or it's going to lead to more of the other problems that we talked about. Double bundle procedures. They've kind of fallen by the wayside. No one talks about them much anymore. There aren't very many people performing them. But I think down the road, if we can find technical platforms that help us with that procedure, that may be an answer that we need to talk about more again. So again, accurate, precise graft positioning, and I think that's a topic that we could spend hours talking about, and appropriate graft tensioning. And what does graft tensioning mean? Graft tensioning is really, you put a graft in and you're securing it, and the distance where it attaches on the femur and where it attaches on the tibia, that distance will change some as you go through your range of motion. And it has to, because you're putting one graft in where two grafts really belong, and so you're kind of splitting the difference. But if you put it in at a position where the tunnels are closest together and tension it, and I don't know if that makes perfect sense to everyone, but the bottom line is if you tension it at that point, you can certainly make that graft too tight. You can make that ACL too tight, and that leads to limitations on motion and stiffness. Osteoarthritis, I think the answers to limiting osteoarthritis is, again, we have to regain full range of motion. We have to limit failures. Failures are bad. It's amazing how bad a knee can be after 2 or 3 episodes of instability following an ACL tear. And a lot of times the injury that they see is not something that we can fix. It's chondral injuries, it's meniscal injuries that aren't fixable. So that's going to lead to osteoarthritis. And we need to have continued work on preserving meniscal tissue. So moving forward, I think we need to find and choose appropriate grafts for patients, preserve meniscal tissue, focus on early rehabilitation with full range of motion being the goal. Then we also need to use transitional rehabilitation where, and again, this is something that's beyond the scope of this talk, but a lot of ACL reconstructions, they go through the early rehab and they're working with the trainers and the therapists that are in the room, and then they get to 4 months and we kind of talk them through that transition back to more normal activities, but we don't have good programs to help them manage that transition, which is probably the biggest weakness in the rehab protocols that we have out there. And I think that leads to more failures because we don't get people really, truly ready to go back and play. And we need a technology platform that makes us better at doing this. So here, and I'll just briefly go through these. This is a picture, and this will just give you an idea of some of the things that you'll see. This is what a new ACL should look like. PCL should be standing up. ACL should be laying down in the middle of the knee. Here's a diagram of how it should lie. It should lie underneath the roof of the notch of the femur. So this is ideally how it should be, and your ACL should enter the tibia just in front of this line, and it should attach clear back here in the back. So here again is a graph that you want to see, and if you'll look, you'll see how it's down on the wall. And this is a graph that is intact, but we ended up revising, and you can see it's attached up here. Okay, so that graft actually is attached up in this point. So you look at that, and this patient had a failed ACL, and that's a technical issue. Here's another picture of an ACL. That's not bad where it enters the tibia, but back here is where the ACL attaches. Here's where it attaches in this patient. So this is a patient that probably got sent to therapy, and then the surgeon blamed the therapist for a failed ACL. We would never do that. And then here's another one that you can see that this, I'm not even really sure where this tunnel starts, but it's so anterior that it's a very vertical tunnel. So you can see the tunnel right down here, and it starts right there. Here's another one. This poor girl she's had 3 major reconstructions, and you can see her femoral tunnel is right there. Tibial tunnel exits right here where it should be here. So she had 3 ACL reconstructions with 3 poor tunnel positions, so she had no chance. Here's another one. You look at this. Here's the roof of the femur. So here's the tunnel. This graft has no chance. It's too anterior, and it's way too anterior on the femur. So, and then another thing that you'll hear about is a bear procedure, which is a new attempt at healing the ACL. And I'm not sure where that'll go. I know that a lot of ACLs that I see are not going to be suitable for this. I mean, you have to have some reasonable ACL tissue for this to work. It's basically it's a bridging procedure to take the ends of the stumps and get them to heal. And but you may hear about the bear procedure. I think the jury's out on that. It will not replace ACL reconstruction. And that doesn't mean there won't be a role for the bear procedure, but there's going to be more patients who are not candidates for this than are candidates for this. So it may be something that we have in our armament in the future, but I think the jury's still out. I know at the sports medicine meeting last year in Washington, D.C., the early results were presented, and they felt like they were on the right track, but they still had a failure rate that was twice the rate of the control group, which was a ACL reconstruction with a hamstring graft. So we'll see where that goes. Also, you know, veterinarians have been fixing dog ACLs for, I don't know, 3 decades by doing osteotomies and changing the slope of the tibia to make it more ACL friendly. And so there's a lot of talk about, do we have a group of patients who have abnormal tibial slope, and that's what leads to this recurrent problem with tearing their ACL again. Now, I think that there are some patients that that's the case, but I don't see an osteotomy becoming the everyday treatment option because there's a lot of complications that go with those osteotomies. I certainly would be reluctant to sign up for one unless it was my last chance hope of having a stable knee. Maybe we'll talk about one of those next year. So, but anyway, that's kind of a confusing topic. I didn't give you really any answers. I think hopefully it's a glimpse into the future of what I think we should be doing better and how we can make it better and what we should focus on. So any questions? Yes.
What are your thoughts about derotational bracing as far as the length, when to start and how long to go with it?
Say that again.
Derotational bracing.
So the question is what are the thoughts on derotational bracing? And really, I think what we're talking about here is putting people in braces or patients in braces after reconstructions. How long do we use them? Some surgeons don't use them at all. I can tell you, I've gone from early in my career, I didn't use them much. I use them much more frequently now, and I don't think there's any science around it. I personally use them when patients start going back to aggressive activities up until about the 1-year mark. And so usually at a year, I transition everyone out of it. There are a few sports where they can't wear them, and I'll take them out earlier. But we really don't know. I think the biggest value is I don't think it really protects the ACL graft against these huge forces that can injure it, but I think it helps with this concept of proprioception or having better joint position sense. And I think there's value to them. I don't know if they need to be, do they need to be a sleeve? Do they need to be a full ACL brace? But I use ACL braces in particularly my high demand athletes to a year. Any other questions? Okay, good. Yes. No, so the question is are we looking for hyperextension in a patient who doesn't have hyperextension in the other knee? And really, when I say hyperextension, the majority of patients have some hyperextension. If you lay them down on a table, you can pull their heel off the bed. I just want them to be back to where they were before they hurt their knee. So I'm really not looking for more than the other side. I want it to look exactly the same side to side. Thank you. Thank you for having us. Thank you for being here.